Welcome to week 5. This week's lecture is on the physical therapy management of pediatric orthopedic conditions. We're going to focus on 4 main ones today, which you've probably had some brief exposure to in ortho, but we're going to go into a little bit more detail. We do not have lab this week. There's time set aside for the Pulling It All Together project. So if you have any questions regarding this lecture, don't wait until we meet again, because that won't be until February 29th. That's the next lab. So my email's at the bottom. You can email me with questions. If it's an in-depth question, we can set aside a time to Zoom. Just don't wait on it. It's better to ask sooner than later. So hopefully by the end of this lecture, you'll be able to describe 4 of these more common congenital or developmental orthopedic conditions. And to really understand and discuss how intrauterine malpositioning helps contribute to these, how to screen for these different conditions using a differential diagnosis, and you should be able to know some physical therapy interventions and also what are the more common medical interventions for these conditions. So these are the 4 we're going to talk about. We're going to start with developmental dysplasia of the hip, moving on to torticollis and positional plagiocephaly, then brachial plexus injury, and then finally clubfoot. So what all 4 of these conditions have in common is that one of the causative factors is poor positioning in utero. And how do you get poor positioning in utero? Well, from a multitude of ways, one of them being premigravida, primipara, where the mom is her first pregnancy and her uterus hasn't really been stretched out, tight space for the baby, can't really move around too well. The mom also could just anatomically have a tight uterus where it's not her first pregnancy, but that's just how her uterus is. Also, congenitally, a mom can have a malformed uterus, and it can be a variety of different malformations. They could be heart-shaped or teeth-shaped or horn-shaped, but whichever one it is can lead to difficulty with the baby moving around or getting stuck in a certain position. You could have a fetal maternal size disparity. So, real big baby, but teeny tiny mom. Same thing. The apartment is, too small for this big baby and they can't really move around that well. And they get stuck and stay in the same position for a while. Multiples. So you put more than one baby in that uterus and things start to get real tight and hard to move around, especially as they get bigger. The last one is oligohydramnios, which means low amniotic fluid. So once that fluid gets kind of low, the baby, again, loses space, has less area to move around. So some other factors can be, a fetus that has some congenital malformations can cause, decreased mobility and, poor positioning. Breech position of the baby. So, by 35 weeks, if that baby is still head up and, tush down or foot down, that's going to put a lot of pressure on the hips and the spine versus the head, which can really withstand that pressure. And I see in the early descent into the vaginal canal really can restrict the baby's natural movement. Okay, let's get into more detail now about developmental dysplasia of the hip. Like I said before, you might see it as congenital dysplasia of the hip, more so in the older literature. We don't really see it too much anymore now because we know that it's not always present at birth. Sometimes it develops, and it's abbreviated as DDH, so sometimes you just see it like that. So what do we need for normal hip development? Well, we need a normal muscle balance. Those muscles have to be pulling and putting strain and stress on the joints in a typical fashion. You need a nice spherical femoral head along with a deep acetabulum that has nice congruency with that femoral head. Okay, we're not going into a terrible amount of detail in this, but we know with normal hip development in the young fetus, the first 3 to 4 months, you have a femoral head, this nice spherical shape, and the acetabulum almost surrounds the entire femoral head. You can notice in the picture, it goes almost all the way down to the femoral neck. So in contrast, what we see by the time the baby's born, after they've gone through their full gestational development, is now that femoral head is growing at a much faster rate than the acetabulum. And as it's doing that, it's pushing out on the acetabulum and kind of flattening out a little bit. And now the acetabulum really only is covering about 50% of that femoral head. So we know what happens with normal development. So what happens with DDH? So DDH is a spectrum of anatomical abnormalities of the immature hip in which the femoral head has an abnormal relationship with the acetabulum, which means you don't have this nice deep acetabulum on a nice round femoral head. So there are 4 types of DDH. The first being a dislocated hip. That's when the femoral head is just completely out of the acetabulum. It stays out there. You may or may not be able to reduce it, but it's going to go back out and stay out. Then we have a dislocatable hip. So that's when the femoral head is resting in the acetabulum, but it can be dislocated. Again, it goes back in and rests there, but it is able to be fully dislocated out of the hip. The most mildest of the forms is the subluxable hip. That's when the femoral head is partially displaced out of the acetabulum. And this, with the dislocatable hip, it really doesn't take too much force in order to do that. But it does, the subluxable hip doesn't completely come out. Now, these first 3 are seen in typically developing infants, as opposed to the last one, the teratologic, which only accounts for about 5% of these kids. This is when the hip morphology is not typical. You'll see changes in the hip itself, and is usually always in a fixed dislocated position. Some of the conditions you might see this in are arthrogryposis, myelomeningocele, which you will learn a little bit later on, lumbosacral agenesis, some chromosomal abnormalities, or in cerebral palsy. This is a common issue in kids with CP. What causes DDH? Well, depending on where you read, the incidence is anywhere between 1 and 34 per thousand. Those sources that used ultrasound as a diagnostic tool reported higher incidences, more on that 34 end. But also cultural practices can influence the chance of getting DDH. So in the American Indian culture, you see the picture in that top right-hand box. So that nice little contraption the baby's in, that mom straps them in so that she can, work and tend to other children, cook, do what she needs to do. But you can see how, the baby's strapped into extension and adduction and really doesn't have much ability to move out of that position. And they might be spending hours a day in that position. The baby Bjorns that we commonly use to carry kids around, that also their legs are hanging and they can kick around, but they're also in extension and adduction. More recently, the company has changed the design to allow for the baby to be positioned in more abduction and hip flexion for that reason. But also swaddling babies at night. We use these swaddle blankets to kind of wrap them up into a little cocoon, which soothes them and lets them sleep well, but it also keeps them in hip extension and adduction for all those hours that they're sleeping. We already talked about intrauterine positioning and how that influences the hip development, but also ligamentous hyperlaxity can cause DDH. And this is due to the relaxin hormone that is used to help mom so that she can accommodate this growing baby and the delivery process. But the relaxin hormone does cross the placenta and can lead to ligamentous laxity in the fetus. We also have things like excessive femoral anteversion that can cause DDH, acetabular antetorsion, where the acetabulum is often that shallow dish instead of that nice deep bowl, and the breech position, which we briefly talked about, especially a frank breech position, which you'll see a picture of on the next slide, where the baby's touched down, head up, but the legs are in knee extension, kind of right out in front of the baby's face, which you can see how just even being in that position can lead to poor development of the acetabulum, but also it's been shown that there's sustained hamstring forces around the hip from this position. And then if the baby is also just resting with their hip against the mom's sacrum or the spine, that can also cause the hip dysplasia. What is the typical history and presentation when you're evaluating a baby for the first time? What are some of the things that you might commonly see? Well, this might be mom's first pregnancy, like we talked about earlier. There may be a family history where, mom or grandma or dad had hip dysplasia. There's been research that has shown an increased incidence in identical twins versus fraternal twins, which lends support to that genetic component. We know that Caucasians and Native Americans have a tenfold increase in having hip dysplasia. And part of that can be cultural, which we discussed on the previous slide. Girls are 2 to 4 times more likely, and I've even seen sources that have said 5 to 9 times more likely. And that may have something to do with that relaxin hormone that we talked about crossing the placenta. It seems that girls respond more to that relaxin hormone. And you may see this more often in the left hip versus the right hip. And that's because the left hip is adducted against mom's spine or sacrum in one of the most common intrauterine positions. And in about 20% of the cases, you'll see it bilaterally. So the breech presentation that we talked about, there's a 5 to 10 time increase in the incidence of hip dysplasia when you are a breech baby. And in addition, you may also present with limitations in hip extension and knee flexion. I mean, if you look at that frank breech position, you can understand why hip extension and knee flexion would be limited. And sometimes a genu recurvatum is present. And what accompanies this diagnosis sometimes is a diagnosis of torticollis, which we will talk about soon, and that's about 20% of the time. Metatarsus adductus and clubfoot in about 10% of the cases. So what specifically are we going to look for when we're doing our examination on these kids? So if we just look at simple hip abduction range of motion, you want to look for symmetry and their range when they're in 90 degrees of hip flexion. So normally you should see 75 to 90 degrees of range. That's their normal range of motion, right? So if there's a difference, if one side only has about, 60 degrees and the other side has 80 degrees, that's significant. Or if both sides maybe only have about 65 degrees of abduction, that's going to tell us there's something going on here. Why this range of motion isn't normal. Either there's a big difference from one side to the other, or there's a significant difference on both sides. This is really going to be your most reliable clinical finding in older infants and toddlers. And then also you're going to pull them into, full extension and take a look at those limbs to see if there's some type of leg length discrepancy. The Galeazzi sign is very helpful when you're putting them into hip and knee flexion. You're looking to see, is there a difference in tibial length? Is there a difference in femur length? And you can find some leg length discrepancy that way, which might signify that the hip might be dislocated, which makes the femur look like it's smaller on one side. You're going to look at the inguinal skin fold, and we'll see pictures of this in a second, where the little wrinkles they're different from side to side. You're going to do an Ortolani or Barlow test, which you'll see a video for in a second, and a positive test is indicative of hip dysplasia, and that's going to be your sign to refer them out. When there's a bilateral hip dysplasia, it is more difficult to identify, but then you have to really go back and look at the simple things like we talked about the range of motion and the inguinal skin folds, and kind of put that whole picture together to see, is this something that's happening on both sides, because the signs are there if you do look. In a typical Galeazzi test, you're putting the baby in hip flexion with their feet flat on the floor, and you're looking in the sagittal view and the axial view to see if there is a shortening of the femur or the tibia. When we're looking at hip dysplasia, We're really only looking at the femur because if the one hip is dislocated, the femur is going to present as shorter. So you can see in that picture, the right side looks shorter than the left. Again, we're looking for a leg length discrepancy by holding the baby's legs in extension. And you're going to look to see if one leg appears shorter. But also, since you're already here in this position, you're going to look to check for thigh skin folds to see if they're symmetrical, if they're asymmetrical posteriorly. And now we're holding the baby's legs in extension, again, looking for that skin fold irregularity. Again, this is going to be more difficult if the baby is presenting bilaterally. This is more useful in unilaterally. And, in reality, it's more useful when you have babies with some nice meat to them. Skinny babies are going to have less skin folds, so it's going to be harder to check. So here we're looking for the symmetry of the inguinal folds. So if you take a look at the first picture on the top left, letter D, that's a normal hip. So if you see the skin folds, they kind of just go about a quarter of the way down and not totally around the hip. If you move over to E, you'll see that the baby's left leg has a deeper and longer skin fold than the right side. So that left side would be more indicative of hip dysplasia. And F, same thing, but you see the deeper, longer skin fold on the right. So now this one we can use a little more easily if there's a bilateral issue, we can help identify. Just knowing what the skin folds are supposed to look like. If you see in G how both sides, the skin folds are going way down and they're pretty deep as compared to the first one we saw. The Ortolani and the Barlow are two tests that we have to test for hip dysplasia. Only caveat is it can only be performed on a young infant, less than 3 months of age. After 3 months, the soft tissues really begin to limit the motion of the hip. And even if the hip is able to be dislocated, you may not get a clunk or a click, which would be your positive sign. The infant also must be completely relaxed. If you have a baby that's crying and screaming and holding their body stiff, you're not going to get a reliable test, and it's just not going to work. So the Barlow is the test that actually dislocates the hip, and you do this by using adduction and some downward pressure, and it pushes the femoral head out of the acetabulum. And you'll hear a clunk or a click. And to remember this, Barlow, out. You want to go out to a bar. That was a little helpful thing so you can remember it. Ortolani is the one that reduces the hip. So you're using the opposites, traction and an anterior pull with some abduction that helps get the hip back into the acetabulum, and that's when you'll hear and feel a clunk. The examination for the ambulatory child is going to vary slightly from the young baby, obviously, because now we can look at gait mechanics and standing posture. And we cannot do the Ortolani and Barlow, right, because the child is now way older than 3 months. So we're really going to look at posture, where we're going to see excessive lumbar lordosis, which goes along with a protruding abdomen, and we'll also see a prominent greater trochanter on the affected leg or hip. You're also going to see a toe-heel gait instead of heel-toe gait with out-toeing on the affected leg, which makes sense if you think about the functional shortening of a dislocated or dislocatable hip, and how you would have to compensate with your gait to deal with that shortening. You're going to see an adduction contracture on this affected leg. So if you think about the hip abduction range of motion that we're losing, and we're not going into that range, the adductors are going to adaptively shorten and become tight. So when walking or in single limb stance, we'll see either a Trendelenburg sign or a compensated Trendelenburg on the affected side. And if the child has bilateral hip dysplasia, you're going to see a waddling gait because of that compensated Trendelenburg on both sides. Now, the child may or may not complain of groin or lateral hip pain. And if they're all the way into adolescence, they may complain of pain that increases with physical exertion. It's important to note that not all late diagnoses are due to poor care. Some children develop hip dysplasia later on, which again is why we know this now, is why we don't call it congenital hip dysplasia anymore, because at birth their hips were quote unquote, typically developing and, looked good, but for a number of reasons, they may have developed it later on, or the child may be asymptomatic. And it just kind of was something that became more apparent when they started walking. As far as imaging, in the young infant, they're going to use ultrasound first. It's more accurate than X-ray. You can visualize hip in motion, so you can see it come in and out of the acetabulum. And they're going to screen every newborn for hip dysplasia, but give a more careful exam to those at high risk. So they might, the pediatrician might do an Orlani and Barlow and check for hip range of motion on all infants. But if there's some risk factors like the being breech in a female, they might do an ultrasound for those infants. They are going to wait till about 6 weeks of age because it can tend to be overly sensitive, the ultrasound can, before that time. But we're going to use the ultrasound over X-ray also because the bones haven't calcified yet. It outlines the cartilage and can detect dysplasia earlier than X-ray in the young infants, and we're not giving the baby any radiation. Now, over 6 months of age, they're going to use X-rays because then the femoral head starts to ossify and it blocks the view of the acetabulum. And you're going to want to see also the uninvolved hip joint along with it. As far as treatment options, we're looking into bracing or open and closed reduction, and we'll go into who is going to get what. So if a baby is diagnosed before 6 months of age, the typical treatment plan is going to be a Pavlik harness. There are other options. The Pavlik is the one most commonly seen. It's a soft harness that maintains the hips in flexion and abduction, but also allows for active motion. The kids can kick their legs, move around. There are potential complications that need to be monitored, including avascular necrosis of the femoral head, femoral nerve palsy, inferior dislocation, and erosion of the posterior rim of the acetabulum. And it mainly is hyperflexion, having the knees up in too much, or the hips in too much flexion that can cause those complications.
Hi, this is me, Devin, and I'm in this picture, and I was 4 or 5 months old.
This is an example of the Pavlik harness. So my middle, Devin, had hip dysplasia on both hips. Both were pretty mild, but she started wearing this at about 3 months of age.
Very young, 3 months.
And she wore it till she was about 6 months. So the rule of thumb is usually the amount of weeks you are when you start wearing it is the amount of weeks that you're going to wear it. So she started about 12 weeks and wore it for about 12 weeks.
That's what she said.
The Pavlik harness is worn full-time up to 3 months. After that time, as long as it's a progression is being seen, it'll be reduced to just nighttime wear only. And usually kids do really well with it, especially when they start before 7 weeks of age. And if not at that time, then they might introduce an abduction brace, which is going to be a little bit more rigid. And that's going to be the next step if the Pavlik isn't enough. The treatment plan for those babies that are diagnosed after 6 months of age really depends on their age of diagnosis. So for beginning walkers, usually they'll try an abduction orthoses that will allow them to walk, and you'll see a quick video of that, what that might look like. If they're a dislocatable hip dysplasia and they're diagnosed after 6 months of age, they usually require surgery. Now, 18 to 24 months could be an open or a closed reduction, but if they're over 2, they're definitely going to go for an open reduction with or without a femoral or acetabular osteotomy, depending on the morphology of the hip at that point. And after surgery, if it's an open reduction or a closed reduction, they're going to wear a spica cast for anywhere between 3 and 6 months. This is a really nice algorithm that shows what the treatment plan is going to be according to age. So you can see between 1 and 6 months, it really depends on if that hip is dislocated and reducible or non-reducible. So that dislocatable versus dislocated hip, whether you're going to try an orthoses or go right to a closed reduction with the hip spica. And between 6 months and 2 years, it's going to be either a closed reduction or open reduction, depending on if the hip is reducible or not. And after 2 years, you're always looking at an open reduction. What's the natural progression of the hip if it goes without treatment? Well, we are definitely going to see morphological changes in the hip joint. They will have pain and will have decreased function. It just varies as to how severe that will be. In mild cases, those ones that sublux, that don't fully come out, we're looking at early onset OA. These might be people who in their 20s and 30s start complaining of hip pain and wind up with a hip arthroplasty at a very young age. And in severe cases where they're dislocated and can't be reduced, those people are mainly going to be wheelchair bound. What is our role as physical therapists with these kiddos? Well, we want to make sure that we're screening for hip dysplasia in the young infant, especially if they're coming in for another diagnosis that has something to do with intrauterine positioning, such as torticollis, brachial plexus injury, clubfoot. And if we see any of those positive signs, such as a positive Barlow or Ortolani, a range of motion limitation in hip abduction, or a significant difference from side to side, we're going to want to make a call to the MD. Whether they're coming in for their hip or their post-surgery or post-bracing, we're going to monitor their gross motor skill attainment and making sure that they're meeting their milestones. Provide gentle range of motion after they've been braced for a long time, especially in that hip spica. They're going to be stiff. We're going to work on positioning with the young infant, parent education, strengthening. We're going to want to get in with those abductors and external rotators, again, especially after they've been braced for a while. But we want to be cognizant on any restrictions they might have, especially post-op. So the take-home message here is that the outcome for a child with hip dysplasia that is diagnosed and treated early is really good. So we see that they'll have a normal hip and very few problems later on in life. When treatment is delayed or they're diagnosed late for whatever reason, whether they were unable to get treated or they didn't have symptoms until a later age, or especially if they don't get diagnosed until adulthood, it's a very different picture. So again, the earlier we can intervene, the better. Next up is torticollis. I guarantee after this lecture, when you're out in public and you see a baby in a car seat or a stroller or anywhere, you're going to be looking at their head and their neck position to see if they have torticollis. Torticollis is one of the more common musculoskeletal injuries that you're going to see in infants. What it is a persistent asymmetrical posturing of the neck, typically with lateral flexion to one side and cervical rotation to the opposite side. Although you'll find in clinic that not all kids follow the textbook definition. Broken up into two different types. So you have congenital muscular torticollis, and this can be with or without a pseudotumor. And these are the babies that mainly are born with torticollis. Or you can have acquired or what's called positional torticollis. And those are the babies that adapt this position over time due to recurrent poor positioning. And torticollis, you should know, is named according to the side of the head tilt. So, for example, if a baby is in right lateral neck flexion with left rotation, that's a right torticollis. If they happen to be in right lateral neck flexion with right rotation, that's still right torticollis. The etiology for torticollis sometimes is unclear. It can be related to birth trauma to the sternocleidomastoid muscle, where there's this hyperextension and a tension put on the SCM that causes micro tears. And in that case, if you see the little picture of the baby, is that tight SCM on the right side is causing lateral flexion to the same side, but because we know the origin and insertion of the SCM muscle, it causes rotation to the opposite side. Again, fetal malposition, which we talked about earlier, how if you kind of are stuck in the same position for a while, you can adaptively shorten and be left with a torticollis. There can be a vascular component, uterine compression, which kind of goes to that fetal malposition, some type of inflammatory condition, container syndrome, which is a newborn kind of being put in a position where, because they don't really have great head control, their head has to flap to one side or the other. And if it's always going to the same side, that side will adaptively shorten, the other side will be stretched out and over weak, and then it kind of is this snowball of not being able to get out of that position. Visual issues can cause a torticollis, as well as gastroesophageal, which we'll get into a little bit more. As we mentioned, there's two types of torticollis. So we have congenital muscular torticollis, in which you'll see fibrosis and shortening of the SCM muscle. And depending on what source you read, anywhere between 26 and 86% of cases will have a pseudotumor located in the midbelly of that SCM. Now, postural or positional torticollis, you might see intermittent head tilts with decreased active lateral head tilt and cervical rotation. Their range of motion passively may be typical in that normal range, but over time they can adaptively shorten, so you might not necessarily see normal range of motion. The SCM is initially tight, but can loosen with stretching. Now, sometimes in some cases, these kids will not always do the typical, I'm going to laterally tilt to one side and rotate to the other side. In some of these cases, you will see lateral flexion to one side and rotation to the same side. And it really just depends on whatever position they've been spending a lot of time in, and those muscles tend to adaptively shorten. So it's not as clear cut and textbook as the congenital muscular torticollis, where you know there's an issue with the SCM and they have that typical lateral flexion and opposite rotation. There are certain impairments that we typically see in a baby with torticollis. You're going to see a shortened and typically fibrosed SCM on the side of the head tilt, where the contralateral SCM is weakened from being overstretched and passively insufficient. Sometimes you'll see a compensatory cervical and or thoracic scoliosis due to the head position and the change in weight shift. Sometimes these babies visually track in only one direction, or they may only be able to track to midline, depending on their available range of motion. Sometimes we see a learned upper extremity neglect. This is due to the rotational component. So for example, if you have a baby with a right-sided torticollis that is always rotated to the left, they may only see their left hand, so they use that left hand and they may forget about the right side. And we're going to see some craniofacial asymmetry. We'll see some pictures of later on, and plagiocephaly, which is a flattening of one part of the head. As always, it's really important to take a good patient history. Some of the things that we want to find out about is the pregnancy. What was the baby's gestational age? Sometimes, babies who are born at 40, 41, 42 weeks tend to be on the larger size. In the last couple weeks, they really didn't have much room to move around and could have gotten their head stuck. Is this one of a set of multiples? And what was the birth order? So, like with twins, for example, sometimes there's one baby that's on the bottom and one baby that's on top, and there's a higher incidence of torticollis in the baby that is positioned on the bottom because they tend to kind of get squished by the baby on top, and maybe they can't really move their head around as well as they would like. What about the birth history? How did the baby present? This, like hip dysplasia, we see a higher incidence with a breech presentation. Also, we want to know what the birth weight of the baby is. Is this a really big baby? Big babies tend to have more difficult births as well as a harder time moving around in utero. Was any assistance needed to help with the birth process? So a vacuum or a forceps assist. That's going to tell us that there was a bit of difficulty delivering the baby, and that can lead to some trauma sometimes in the neck. How about a good family history? There's not really a genetic component to torticollis, but it's good to know if there's any other developmental issues that are prevalent in the family. And we want to know about the baby's hearing screening. All babies are screened for hearing issues in the hospital before they're discharged. So we want to know if they passed that test, if the parents have any concerns over hearing or vision for that matter. What about the age of onset? When did the parent first notice that the baby was not really moving their head or was stuck in a position? Sometimes parents recognize right away and bring it up to their pediatrician. And sometimes it might be present right away, but the parent doesn't realize it until the pediatrician mentions something. And then they start looking back at pictures and say, oh, yeah, now I see their head was always tilted to the right. But sometimes they'll say, no, everything, it was good. But now at like 3 months, we're starting to notice that she's not moving her head, all the way to the right. How about any other diagnoses? We know that GERD is more prevalent in kids that have torticollis than in the general population. And Sandifer syndrome is another issue that we see. It's a dystonic movement disorder that occurs with GERD. But in this one especially, these babies have these almost like seizure-like episodes that can last anywhere between 1 and 3 minutes, up to like 10 times a day, where you see this excessive trunk hyperextension and they kind of rotate their head away. And that's an attempt, they think, to kind of clear and bring some pressure off of the esophagus to relieve some pain. And they think, sometimes with GERD, it's the same way that they're rotating their head away because of a pain response. So those are some things that we want to know, as well as any visual impairments that may have been diagnosed. And motor milestones, we want to know where the baby is up to and get an idea if they are, on par for their age or if this asymmetry is causing any issues with their motor milestones. And as always, if the baby's on any medications. In the PT exam, we're going to want to look at some specific things, and this includes measuring active range of motion and passive range of motion of both lateral neck flexion and rotation. And you're going to want to look at if there is an asymmetry between right and left, and or if there is a difference between the baby being able to actively move through the range versus passively getting through that range. Normal cervical lateral flexion can get up to 70 degrees, and rotation, believe it or not, can get up to 110 degrees. Now, the research shows that cervical rotation tends to be a more reliable measurement than lateral flexion. So we tend to rely on that measurement more often when we're documenting progress. You want to look at the strength of the baby's neck. So to see if there's an imbalance between the right and the left side. So you do this by assessing their neck and trunk righting reactions. So when you tilt them to one side, are they able to right themselves past midline? Are they just holding midline? Or is their head below midline when they're tilted to the side. You also want to look at skin integrity. So on the side of the lateral tilt, sometimes you'll see redness and even skin breakdown from the lack of oxygen getting to the skin due to that head tilt. Obviously, the more significant the head tilt and the stiffer the flexibility is, the more skin issues that you're going to find. Spinal alignment, so you're going to take a look at not only the neck alignment, but also the whole spine, going through to see if there's any of those compensatory scoliosis going on. Muscle tone, you want to take a look at, is there any tonal implications? Does the baby have low muscle tone, has a hard time holding up their postural alignment? So you're going to take a look at, clonus, Babinski, all those things to see if there's some sort of CNS involvement as well. You want to look at their upper extremities. Are they using them symmetrically, or is there evidence of a learned neglect? We want to look at the attainment and the quality of their gross motor skills. And we're going to do an ortho screen because we know torticollis is associated with intrauterine positioning. So we're going to want to look at all those other diagnoses that we're talking about today and screen for those, because if you have one, you may or may not have the other or one of the others. And we're going to look at their plagiocephaly, their head shape, and any craniofacial asymmetry and document that as well. And we can document pain by using the Flack scale, and I'll show you that in a second if you're not familiar. Since babies can't tell you if they're in pain, this is the scale that we'll use for that. As an adjunct to your PT exam, you're going to want to use some type of standardized outcome measure to get a clearer picture on, if the torticollis is affecting the baby's ability to attain age-appropriate gross motor skills. The AIMS is one that's available to us, which you can use between birth and either the time the baby starts walking or 18 months of age, whichever comes first. And that was observation only. That's a nice, quick tool to use that does go into, baby's quality of movement, weight-bearing patterns, things like that. The TIMP is another one that we have for the young ones. So you can only use it till they're 4 months of age, but that one's nice because it has predictive ability. And the Peabody 2 is another one where it's longer age range. You can use it until 6 years. And again, this one's not predictive and it's not going to be sensitive to showing changes in the torticollis. However, these are good to use to see where the baby's at and maybe if a referral to early intervention is warranted. This is a baseline joint goniometer that's being used to measure the baby's neck rotation and also lateral flexion. It's a pretty basic tool. Runs about, 45, 50 bucks, so not a huge investment. It's a little bit difficult to control the baby's body and also holds the goniometer up. So it helps to have assistance. You can make sure that if you see the picture at the top right, it almost looks like her left shoulder is coming up off of the plinth a little bit. So you have to make sure that you're really stabilizing. These pictures show an example of an arthrodial goniometer. It's a little bit easier to use than your traditional goniometer. Where the nose lines up, so you can see how mom is keeping the baby calm. And just making sure that the baby's neck is in neutral. Sometimes the goniometer and making sure letting it hang off level with the horizon and that the baby is calm and you're not like manhandling them. Is a little bit, but this is just something that we have available to us to help us. And then the bottom pictures are showing lateral flexion, but this can be a less reliable measurement. If you see, especially like the bottom left picture, the baby has a little bit of rotation. There can be a little bit more compensations that are going on when they're, doing lateral flexion. That makes that measurement a little bit more difficult. Plus, then you're trying to bisect the baby's face and see where they line up on the lines, which you have to keep in mind too. There can also be some craniofacial asymmetries as well. This is the Flack scale. So this is a observational scale that we can use to document pain in babies. There are 5 categories looking at the face, legs, activity level, amount of crying, and ability to be consoled. And it gets scored between 0, 1, and 2 for each of the categories. So you can have a total score between 0 and 10, where 0 is no pain or distress, and 10 is a high level of pain and distress. We want to make sure through our exam that what we're looking at is truly torticollis and not coming from another cause. So some of the non-muscular causes of torticollis can be things like a cervical skeletal malformation, like a hemivertebrae, or a subluxation of cervical vertebrae, something like Grisel syndrome, which causes ligamentous laxity, can lead to a C1, C2 subluxation, which kind of holds the head in a rotated position. You can have a herniated disc. There's some visual issues that can cause what looks like torticollis, like extraocular muscle paresis, strabismus, nystagmus, a visual field deficit. These can occur sometimes later in infancy. Um, After the infant develops head control, you see it more when their binocular vision is a little clearer. Then they might use head rotation to steady their eyes if they're having like a nystagmus or a double vision. So that's something you're going to want to rule out, and you can usually tell this by um, checking their positioning versus their range of motion. A lot of times these kids with the visual deficits won't have as significant, if any, a range of motion limitation. And if there is one from positioning, it usually can loosen up relatively quickly and you get full range pretty quick. So some other causes that we already talked about, GERD and Sandifer syndrome. And GERD and torticollis can go hand in hand. It's not that it's not torticollis because they have GERD, but it's important to know that if the GERD continues to be not treated effectively, that positioning really isn't going to change if that's what they're using to relieve some of their pain. So studies have shown that it's harder and takes longer for kids with GERD to achieve a midline position, and especially when the GERD isn't well controlled. Some other causes are birth injuries like a clavicular fracture or brachial plexus injury, or some neurological conditions like spinal cord tumors, which you're going to see more neurosigns like vomiting, um, some nystagmus, things like that. Or is there some tonal implication? Is there a CNS insult that's causing some tonal implication that's causing the what looks like torticollis? There are some craniofacial changes that we see in these babies with torticollis, namely craniofacial skeletal asymmetry and positional plagiocephaly, and we'll see some pictures and examples of both. This baby is demonstrating some of the facial changes that we can see with torticollis. So he has a left-sided torticollis who's tilting to the left. You're going to see that same side, the left side, the eye is smaller, it is less round and open, and it's slightly higher than the other eye. And it's not just the tilt. Like if you put this baby in midline, there is a discrepancy in the height of the eyes. Same thing with the ear on the same side. It's going to be pushed up a little bit higher, and the actual ear itself, the cup, kind of gets pushed forward, so it's sticking out a little bit more. The jaw on the same side is flatter when you look at both sides. And on the other side, the contralateral side, the ear is pushed into the surface, so it's flattened. And you see some, we'll talk about this more with the plagiocephaly, but because of the flattening of the head in the back, now you have on the opposite side some we call bossing, so it sticks out a little bit. So then on the opposite side of that, which would be the contralateral side to the head tilt, you'll see a little flattening in the front. This isn't something that I normally point out to parents. It's something that I monitor, and these babies do have a chance to naturally correct this as the torticollis resolves. And really, they have until about 18 months until those sutures um, fully closed, where they can make these changes naturally. These pictures show some of the changes that can happen to the skull shape when babies have atypical pressures on the head. So the first picture on the left shows a typical baby, nice, roundness all around, easy to rotate the head side to side. The second picture is our typical plagiocephaly noted when we have a baby with torticollis. So if this baby is tilted to one side and rotated to the opposite, so this one would be a left torticollis if the nose is up, which it looks like. So it's tilted to the left and then rotated to the right. You can see with that right rotation how that back right side of the skull is going to flatten from having the pressure on it all the time. Now you see the skull has to go somewhere so that there's some bossing that happens. So on the diagonal from the flattening, you get a little bit of bossing there. And you can see how that little kind of bump on the back of the head would make it hard for the baby to turn their head all the way to the left when they're on their back. So not only are they, weak on the contralateral side, making it difficult to turn, they have tightness on the side of the torticollis, which makes it difficult to turn. But now they have this bump they have to try to get over with all these other issues going on. So you can see how that kind of perpetuates the rotation to the one side and resting in that position. Brachycephaly is, you see this more so in babies who have low tone and they just are spending a lot of time on their back. So the back of the head is more flat than the sides. And the scaphocephaly, this is one that's like football shaped head, they kind of call it. You see this more often in NICU babies where they're so good at positioning the baby, but they tend to go right to left, right to left, right to left. So they get flattening on both sides of the head, and then it's longer from front to back. So this position also leads to some difficulty rotating the head right to left because there's kind of a large bump they have to overcome. As physical therapists, we don't directly treat plagiocephaly. However, as the torticollis improves, the amount a child will rest in that same position on that flat side of the head will decrease. They might spend more time on their belly or in sitting off of their head, so that gives time for that head to reshape. However, for severe cases or cases where the child has been sitting and off of their head for a while and the plagiocephaly isn't improving as much as they like, there is a controversial treatment method where we use helmets to treat the plagiocephaly, and this is done by an orthotist, but it's called a DOC, a dynamic orthotic cranioplasty, and the baby wears it for like 23 hours a day. Basically, when they take a bath, they can take it off, but they're going to wear it all other times. And it gives a little pressure on the areas that are bossed out, and there's a little opening for the areas that are flatter, so it can help round out the skull that way. In 2013, the APTA devised this clinical practice guideline for congenital muscular torticollis. It has since been revised in 2018. It's a wonderful resource, and we really don't have many of these in pediatrics, which is unfortunate, because if you really want to go into pediatrics, I implore you to download this and have it at your disposal and really read through it. It really focuses on education, especially with pediatricians, nurse practitioners, people who are referring to PT, to kind of go against that let's wait and see type of attitude and really showing them how getting in there early really is the most important thing. It developed a severity classification system for torticollis, which is really great for guiding your treatment. And it talks about which treatment has the best evidence for it. This clinical practice guideline really focuses on early education. So encouraging medical personnel to educate expectant and new parents within the first 2 days of birth, but really broaching the subject prior to the baby's birth. about how important it is to have supervised tummy time at least 3 times a day. Now, the Back to Sleep program is, wonderful, and it has prevented so many infant deaths. But the effect of that, where the baby's not spending, 11, 12 hours laying on their belly at night and moving around and strengthening all those extensors, the outcome we know is motor skills are delayed. So some research has been done to show how much time do babies need to spend on their tummy to counteract the time that they're not spending sleeping on their belly. And two of the main studies have shown, one said 80 minutes of time on their belly, not consecutive, but added up throughout the day. And the other study said 80% of waking time babies should be on their belly. Now that can be very overwhelming for a new parent. So saying maybe 3 times a day, to start with is a good place to start. But when you start to see babies for torticollis, you talk about how much time really needs to be spent on their belly to really help that torticollis improve. And for the parents to look for full active movement, to talk about positioning to prevent the torticollis, so avoiding the same head position for a long time, whether it be in a swing or a bouncer, and really talking about, minimizing time in those containers as well. And, talking about the role of PT, so parents know where to turn when they have some concerns. This is a very complicated looking slide, but it's really not that bad, I promise you. This is the clinical practice guideline algorithm for classifying the torticollis into severity level and also to help with decision making. Now, it's broken up first into the age where the asymmetry is first noted. So we're talking about birth to 6 months, the early intervention, later intervention being birth to 12 months, and then very late is really at any age, but it's only more than that, more than 12 months. So if you look at the early intervention, that now is broken up into, is this baby coming in the first 90 days or between 4 and 6 months? So after you break it up into that group, now we're looking at, from your evaluation, is this a postural or positional torticollis? Is there a muscle tightness difference? Looking at passive rotation from right to left, is the difference less than 15 degrees? Those two will lead to a grade 1, which is an early mild severity. Now, if you're looking at a muscle tightness between 15 and 30 degrees, that's a grade 2, early but moderate. If the muscle tightness is greater than 30 degrees, or if there's a palpable pseudotumor in the sternocleidomastoid muscle, then you're looking at a grade 3, early, but it's more on the severe side. Now, if you look at the later intervention, so the age the asymmetry is noted is really between that 6 and 12-month range. That's again broken up into 2 age ranges. So the earlier end of that later age, 7 to 9 months, and then 10 to 12 months. So again, we're looking at, from our evaluation, is this more of a positional or postural torticollis, and is the muscle tightness less than 15 degrees? Then we're looking at a grade 4, which is a later mild case. Is the baby older but has a postural torticollis or a muscle tightness less than 15 degrees? Then we're looking at a grade 5. So that's just changed based on the age of the baby. If you're looking at, regardless of the age, of the muscle tightness is between 15 to 30 or greater than 30, you're looking at a grade 6, which is a later severe. And if the baby is older, more than 30-degree difference from side to side, or if there's a palpable mass, then you're looking at a grade 7, which is called later extreme. Sounds very scary, right? Then there's the very late intervention. So that we're talking about, the baby's not coming to PT till after a year old. These are tough, tough cases. And it happens, I will tell you. Not a lot, but it does happen. So regardless, at this age, if it's positional, regardless of the difference from side to side, or if there's a mass, you're looking at grade 8, very late. Okay. So that, in that case, the arrow goes to the, treatment area, but really you're talking about the options with the parent, because you might want to try PT and try some of these more alternative treatments, but they're also going to want to have a consultation, maybe for surgery, for Botox, for, some less conservative method of treatment, because the kids conservative PT alone hasn't been shown to be super effective in this age. Okay. So now that you have it broken up into severity levels, you can give the parent an idea of, how much intervention might be warranted, the prognosis. And if you keep going down, it does, give you guidelines for um, discharge as well. This algorithm from the clinical practice guideline is great for helping you decide when a referral is necessary. And it's great to share with physicians also. So it looks at, in the first couple days of life, when you're giving that education to parents about, preventing poor postural alignment and making sure they're getting enough tummy time. We're going to look at the birth history and the any issues with birth trauma, basically taking a little history to see, does this baby have any high risk factors for torticollis? If no, the birth history was good, your little physical exam was good, the infant's physician is really going to monitor the baby throughout infancy. And, if some sort of delayed onset torticollis appears, then they're going to refer to the pediatric PT. A sudden onset of torticollis without a CM impairment, that they're going to want to refer for additional exam because there may be something else going on. But now the babies that do have a more high risk due to the history and the birth trauma and other things like that, the facial asymmetry, all those things. So those babies are going to be referred right away to the pediatric PT. And even the ones that, the maybe is noted at the first, 2 or 3 months of life at a well visit, those get referred to the pediatric PT. Now the PT during their exam, if there's certain things that come up, like an abnormal visual screen, then you're going to want to refer to ophthalmology. If any non-muscular asymmetry is noted, maybe some imaging might be warranted. If there is really severe facial asymmetry or plagiocephaly, especially if the baby's older than 5 months, then you're going to want to refer out for possibly a helmet. If you find an orthopedic, in your orthopedic screen, there's some abnormal findings. So we're looking at hip dysplasia, brachial plexy, clubfoot, all those things. Then you're going to want to refer to ortho. And any abnormal neuro findings that you see, you're going to refer to, obviously, pediatric neuro. So this is just a good algorithm to follow so you know when it's appropriate to refer out. And then, it's also helpful for the physician to know, when they should be referring to PT. This clinical practice guideline also outlines which treatment techniques have the most evidence to support it. And neck stretching and passive range of motion is one of them. However, there's not a real consensus on the best stretching techniques, the number of reps needed, the duration of the hold for the stretch, rest periods, etc. However, there was one study that reported the increased frequency of stretching as being more beneficial, with more improvement in head tilt and cervical rotation when done 10 stretches 10 times a day versus 10 stretches 5 times a day. So that's a little bit of guidance that you can give to parents. Active range of motion for trunk and neck has also been shown to be helpful. And you could do that by, visual tracking, using toys to get them to look side to side, even putting certain things up in the crib against the walls. If you want them to look, to rotate to the right, you might want to put a little, a little like aquarium that you can kind of set up and play, and it turns lights. It will attract the child to actively rotate their head to that side. The Trying to develop midline and symmetry is really, really important for kids who spend a lot of time tilting their head or rotating to one side. After a while, they start to think that that's midline. And then when you put them in midline, they feel off. So they go not because that they're tight, but because it feels more natural for them to be in that tilted or rotated position because they never really developed or got a sense of where that midline really is. And again, the symmetry, we want to really focus on their, symmetrical upper extremity use and avoiding that learned neglect. Environmental adaptations are important too. So we're, avoiding containers. We're talking about positioning during the day, different holding positions that you could use, things like that. And parent and caregiver education is huge, 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 huge. So really getting the parents to buy in on the fact that treating torticollis is not done in the 30 or 45 minutes that they're in PT that week. So it really needs to be done consistently throughout the day for any real changes to occur. And that's when the parents come in. You have to make sure that they are comfortable with the stretching, that you give it to them in ways that they can do it easily throughout the day and it's not setting aside therapy time. And really getting them to buy in on that tummy time and really gearing towards that 60 to 80 minutes of cumulative tummy time each day. What does a comprehensive home program look like for parents? Well, like I said before, you're going to get them very comfortable with doing the stretches, active range of motion, passive range of motion. However they play with the baby, you're going to teach them how to use toys to get them to move the way you want them to. And depending on how they hold them, that can help either strengthen or stretch the muscle that needs to be addressed. And I'll show you a picture of that in a little bit. Also, positioning, so educating them on minimizing the use of containers, but also when they are in those containers, you can fold up some receiving blankets to put on the side of the head tilt and the opposite rib, same side hip to really give a nice 3-point positioning to hold that baby in midline and not allow them to tilt. And really the same thing, focus on symmetry, getting them aware of, using the right side and the left side equally. And all that goes into parent education as well as how important it is to do it and what type of motor skills to be looking for and how they should be doing it. Now, the exercises for the child obviously need to be comfortable. If the baby is screaming their head off during the stretches, then what I usually advise parents to do is, just put your hands there, hold it in the position, but don't actually stretch. Just get the baby comfortable with having their head held because sometimes that's anxiety provoking. So it might take a week or two to get to the point where you're actually stretching, but it's so important to get that baby comfortable. You don't want a screaming baby. You don't want one that's really fighting against you. They need to be simple, the exercise. You can't give them these complex things because they just won't get done then. And really, it needs to be incorporated into their everyday routine. Like I said, it shouldn't be set out therapy time because everybody's busy, and especially new moms are they're just overwhelmed. So saying that, every time you change your baby's diaper, leave them on the changing table for a minute and do your stretch. Start with 20 seconds and see if they can tolerate that. And as you go on and on and on, try to hold longer and longer and longer. And you do this after every diaper change, you're going to get a good, depending on how much your baby goes, 5, 7, 8 times a day getting those stretches in. Bath time is another time I love to give parents something to do right after because their baby's relaxed, their muscles are relaxed from the nice warm water. That's a great time to do some neck massage and some stretching right after. And just how they hold the baby throughout the day can get stretches and strengthening in without it being quote unquote therapy time. Even using the bottle. So if they're being bottle fed to kind of rotate the head a little bit, hold the bottle in a little bit of, if you're looking to get left rotation, just a little bit off of midline. So you're getting a little bit of left rotation as they're feeding, and they're doing that multiple times a day. So just little things that they can do in their daily life that doesn't take any extra really time out of their day. Here is a picture of a baby with a right-sided torticollis being stretched into left lateral flexion. So we teach the parent to keep the baby flat on the ground. We really don't want a lot of neck flexion. Sometimes if the baby's wiggly and they're rotating their head side to side, I will have parents put their hand under the baby's head so their fingers can kind of cup the head to control the rotation a little bit more. But I always tell them, like, make sure you're not lifting your hand up towards you because we really don't want any neck flexion. The parent needs to hold the opposite or that same side shoulder so that the shoulder doesn't come up, because you know the SCM attaches to the clavicle. So if you're not stabilizing that shoulder and you're starting to pull, that shoulder will just come up and you're not really getting an effective stretch. Also, you want to make sure the baby's head, the face stays in midline. They're not rotating side to side. So getting them to lock eyes on you is helpful. Keeping their eye contact will help keep their head in neutral. And again, I usually guide parents and say, start the first one, 10, 15 seconds, see how they tolerate it. Next time, try a couple more seconds, and you're just going to work your way up to eventually you can really hold the stretch for, even 2, 3 minutes at a time. This picture shows that alternative method of holding. So you see how, like, the fingers come around and can really control a wiggly baby if their head's moving side to side. And if you can't really do it flat, with the baby flat without having their head come up, you can hold the baby on your lap if you're sitting in a chair and kind of have the head off of your knees, in front of your knees. So that way you can hold the head in neutral and it's not being flexed at all, and get that stretch that way. This is a picture of a cervical rotation stretch. So this is a baby with a right torticollis, so naturally wants to go into left rotation, but they're being stretched now into right rotation to stretch that right SCM. So the way that I normally do this is I will give the baby something visually to track to get them to rotate as much as they can actively to their right side. Once they get to that point where they can't go any further, then I'm going to give them a little overpressure from their head. So your opposite hand needs to hold the shoulder down on the opposite side. So that way they're not lifting their shoulder up and rotating their body with them as their neck rotates. So then, for example, in this picture, I would take my right hand and use that toy to get them to track and actively rotate as much as they can to their right side. Once they get there, I leave the toy there so they can continue to look at it, play with it, reach for it, and then use my hand on the side of their head. They're kind of like by their temple, to give a little bit of overpressure if they can handle it, or just hold them there if they can't. Now, notice that she's not pushing on the baby's cheek. We really don't want to go anywhere near there because we don't want to mess with the TMJ. So really keeping it on that temple area is important. Now, another thing to be mindful of is, it does not happen often. It's in a very, very, very small percentage of babies, but you have arteries that go up your cervical spine. So you always want to make sure you keep an eye on the baby's eyes. If you see any type of nystagmus when you're holding this position, just back off. Back off a little bit, and watch the eyes. They should stop, because we really don't want to occlude any arteries up there. That would not be good. This picture shows a side-lying hold that's really easy for parents to do. They can carry their baby around the house like this during the day. And really, you could do it in 2 different ways. So if you have the baby's head supported in the crook of your arm right there, they kind of sink into it. And if you lift the tush up a little bit, then they get into more of a C shape. So that would stretch the SCM. In this case, it would be the baby's left SCM. Or like this mom is doing, and you could even do it a little bit more. You hold your hand a little bit lower and the head is unsupported. So the baby has to hold their head up against gravity. That's going to strengthen the contralateral or the right side SCM. to help with that muscle imbalance and create better symmetry. Um, Another nice thing to do, you teach parents, is you use this holds and put them in front of a mirror so they can see themselves. And they might lift their head up a little higher. They might even reach up to the mirror. You can put little, sticky things on the mirror, little, like they have these little bath toys that stick when they're wet to the side of a bathtub. You can wet them and put them up on a mirror. And then the baby can reach up and grab those too, and that really activates their contralateral side and it keeps it more engaging and interesting for them. So they might hold it up a little bit longer. This is an example of that football hold. It's better with little tiny babies. Um, and yeah, I love this picture because that little baby looks so angry, doesn't it? But if you're positioning the baby to the side where the opposite side of where they're comfortable rotating, so we're getting a rotation stretch that way. And you're getting a little tummy time that way. So every time they kind of lift their head up, they're activating their extensors. And this is even a good position for babies who have some GI issues or colicky. It's a comfortable position for them to be held in. This slide shows a baby in an infant carrier with receiving blankets, propping them up in that 3-point positioning. Now, it's important if they're in especially a car seat that you do this after the baby is secured in the straps, so you're not affecting the tightness of the straps at all. But so this baby would have a right-sided torticollis. So the one folding blanket is on the right side of their head, keeping their head in midline. Now, if that's all you did, the baby has a little wiggle room in the trunk, so they could slide their trunk over a little bit to take some of the stretch off of the right SCM and get it back into that tilt a little bit. So that's why we put a second one on the opposite side of the trunk and then a third one on the same side of the hip. So it really locks them in and they can't really wiggle their trunk around. And there's other, you can do this in a swing, in a bouncer, other, containers that if they have to be in for, a little bit of time, we're going to make sure that they're well positioned while they are in there. This is another positioning device. I don't believe it's on the market anymore, but there may be one similar to it. This is good for those babies who are really resistant to holding their head in neutral with those receiving blankets. Now, you can't use these in a car seat because they're not crash tested and they actually have a Velcro that loops around the car seat strap. So it does affect the car seat. So I would not recommend this in a car seat. However, if you're home in a bouncer, in a swing, in something, you need a half an hour to get laundry done, but you want to make sure that the baby's not, totally tilted or rotated in that time, you can use these elephant ears to hold them in neutral as long as it is not a traveling device. Okay, quick, top baby, name the side of the torticollis. If you said right, you would be correct. So this is just showing, a teeny tiny baby. There is that head positioner that is in the car seat, but it's not really doing an effective job. Um, this is a teeny tiny baby. For older babies, there's things that you can even do in the car where if you have the handle upright in front of the baby and, some parents like to hang toys, you would push all those toys to the baby's right side so that it's going to rotate and look to the right to look at those toys. A mirror in the back seat. So, sometimes really attracts a baby to look at their reflection in the mirror or try to look up at mom. So if you have that more off to the right, that would encourage some right rotation. Um, the baby on the bottom is showing nice midline. That's a bouncer. So that's something you see, it's just kind of like a sling. You see how easily that a baby could like just kind of flop over without any, support whatsoever. So that might be something where we try some receiving blankets, but there's really nothing to prop it up against. Um, Luckily, those toys are keeping the baby's attention, holding their head in midline. But this might be something where I just tell the parents to kind of, avoid that type of um, positioner if they can't really keep their head in midline. There are some alternative treatments that are available, and we usually go to these when we're not having success with the traditional conservative methods. There are options for kinesiotaping. There really is low evidence, so it's not usually recommended. However, on a case-by-case basis, if you have a child that's just not responding, that this is something that you can try and see if there's a benefit. You will know right away if it's helping or not. So I've used this for some kids who are still tilting out of habit. So they have the range, they have the strength, but they just keep tilting out of habit. So I use the kinesiotape to activate either the SCM or the upper trap on the other side. And I would say in probably about 1 out of every 3 I try it with, I will see some active change and better midline hold. But the 2018 clinical practice guideline um, has more evidence now indicating that there's no real benefit to kinesiotaping. There was a 2016 level 1 study that also suggested there was no added value to kinesiotape when provided for 3 weeks in conjunction with other conservative methods. So that being said, it's something in your toolbox to look for if other things are not working, but knowing there's not strong evidence. So you try it, you don't see a change right away, you toss it and try something else. We also have things called tot collars, soft collars, Kentucky collars. These are, again, a device that you put on the child, and it is useful more for those kids, again, who have that range of motion, they have the strength, but out of habit, they are not holding midline. You'll see a picture example of these in a second. Again, low level evidence, not for every kid, but every once in a while you'll find someone that responds well to it. The first picture on the left is an example of the tot collar. So it's basically just plastic tubing that uses a kind of a bracket that holds it further apart on the side that the child's tilting to, and it's less high, I guess, on the opposite side. So it allows active lateral flexion to the side that you're trying to get to, and blocking lateral flexion on the side that you don't want them to tilt to. Again, child needs to have good range of motion. And the other one is a Kentucky collar. I mean, I think you'd have to be a sadist to put a child in this. So you imagine the kid walking around all day with their head strapped to this thing. But I get it's there if desperate times call for desperate measures. It's something that's available. Some other alternative treatments are Botox. If you have a muscle that is, super resistant to lengthening, Botox can be an option. However, there are risks. You are close to respiratory muscles when you're injecting into the neck. So that's something that, parents need to be aware of, that it's not without risk, the Botox. And again, it's not permanent. You have a window of opportunity then to try to get in there and stretch that muscle out. Microcurrent, there's actually some new and even newer evidence that microcurrent does have some benefit, especially when it's combined with traditional treatment techniques. Um, there's one resource that you'll see a nice article that talks about a child that was diagnosed later on. So one that we would more consider in that classification to be severe and maybe, refer to surgery. They tried this microcurrent and they were actually able to get some nice results with the microcurrent and the traditional PT. And soft tissue mobilization, which I kind of talked about, is a good time to do after a bath and right prior to stretching. And they found that works best when combined with stretching and active movement. So you do a little soft tissue first, then you do some stretching, get the baby into a new range of motion, and now they have to, use that muscle, strengthen that muscle in that new range of motion. So there is some nice evidence for that. What is the prognosis for these kiddos? Well, it really depends on their severity and the age when they started treatment. So you can go back to that algorithm, and that gives you a good idea of, how well these kids are going to respond to conservative treatment. Surgery, thankfully, is rare, and it's really, set aside for those that are most severe, especially those that come really late to the game, and don't respond well right away to conservative therapy. The length of the treatment really also depends on the severity. So, anywhere between 2 and 5 months, but it really depends on the age of the child and, how severe we're talking their torticollis is. How do we know when we should refer back to the pediatrician or, the referring physician? If the baby's older than 12 months and there's a difference of more than, 10 to 15 degrees of passive or active cervical rotation or lateral flexion, then the chances of conservative therapy really having a good prognosis for this child is low. You may want to continue with therapy as the child, as you're referring back, but they or probably should be seeking other options at that point, at least as a consultation. If the presence of that pseudotumor is still noted after 6 months of age, that's something that we need to refer. Any non-muscular causes of asymmetry, which we talked about, at the examination portion, any visual changes, visual causes, hearing, gastro, anything like that, neuro, orthopedic, then we want to refer back. If the torticollis changes in side to side, or there's a change in the location or the size of that pseudotumor, that's another reason to refer back. And if this baby you've been treating conservatively and using all your, tricks in your bag for at least 6 months, and they've been plateauing after that 6 months, then we need to refer back. How do we know when to discharge these kiddos? Well, luckily we have that clinical practice guideline to give us some criteria. So we want to look for a difference in the child's passive range of motion in left-right cervical rotation within 5 degrees of each other. Movement should be symmetrical, upper extremity use is symmetrical, their head movement is symmetrical side to side. There really shouldn't be any glaring asymmetry. Their motor skills should be in that age-appropriate range using our standardized outcome measures to help guide us. And there should be no visible head tilt. This baby should be able to hold midline for the majority of their day. We really need to have the caregiver have good understanding of what to monitor in the future, to look for the head tilt returning, when to initiate stretches again and active movement again, and when to bring the baby back. Now, if all these discharge criteria are met before the onset of walking, it's recommended that the parents bring the baby back in for follow-up after they've started walking. Or they say 3 to 12 months later, depending on when the baby was discharged. So it's important because now the baby's upright and, like I said, a new skill, they kind of revert back. You might see that head tilt come back as they're learning a new skill, but after they become, a master at that skill, they should be able to hold midline again. But it's important. Walking is a new dynamic skill that you really want to see how these kids are doing once they start walking. So to bring them back maybe for 1 or 2 sessions just to monitor, that sometimes that's all that's necessary. So this is our ultimate goal, right? So this is a baby that has gone through treatment, and now look at this nice midline position. If you notice, the left eye still is a little bit smaller than the right, but pretty good facial symmetry, a little change in the folds of the lip, which tell you that there might be some changes in the chin. But all in all, good midline hold, and you can't tell by picture, but hoping they have a nice side-to-side movement. If you notice that little hat she's wearing isn't just, to keep her head warm, this is another example of something that can limit rotation. So this would be limiting the rotation to her right. So there's that little kind of like almost like a side ponytail coming down from the hat, that's giving a little bump that makes it hard for her to rotate to the right. What happens if we don't treat? What's the natural progression of torticollis? Back in the day, they used to think that most of the kids will spontaneously recover by a year. We know now that that's not the case. Spontaneous recovery is actually pretty rare. And if you wait until a year, it's going to be really, really difficult to make any progress with these babies. We know that the soft tissues might not grow in relation to the child's skeletal growth, kind of similar to what you learned in cerebral palsy, where it just can't keep up with the bone growth, which can lead to that compensatory thoracic scoliosis as well, that learned neglect. And you can even get windswept hips from being in that rotated position. The legs are going to kind of rotate and sweep that way in that position too. And you also get shoulder elevation. So the shoulders are not going to be level. And you even can get some other dysmorphic changes with the shoulders and the scapula as well. Moving right along, next up, we're going to talk about brachial plexus injury. And that's exactly what it sounds like. It's an injury to the brachial plexus. And in the literature, you might also see it written as brachial plexus birth injury, obstetric brachial plexus injury, obstetric brachial plexus palsy, or neonatal brachial plexus injury. How does a brachial plexus injury happen? Well, it can be an obstetric injury that can happen during a difficult vaginal birth. So if their baby is breech and for whatever reason is not being born via C-section and they're actually trying to deliver vaginally, if as the baby's coming out and they're coming out tush first, then the arms have to go up to kind of clear their way down. You can have a traction injury on the neonate shoulder during that type of delivery. In a typical head first delivery, if the shoulder gets stuck and you're still pulling on the head, the doctor's still pulling on the head, but the shoulder's stuck, you can get a traction injury that way to the brachial plexus. And even if there's just a large amount of traction and rotation of the head done during delivery, that can also cause a brachial plexus injury. But it could also occur due to trauma, or having some sort of vertebral anomalies, either cervical rib or some sort of thoracic vertebral anomaly. There are three types of brachial plexus injury. Erb's palsy is the most common, and that's the one that we're really going to focus on with this lecture. That occurs with damage to the upper trunk, so we're talking C5, C6, where the arm is held in what's called a waiter tip position. So as if you are trying to hold out your hand with some money in it to give it to somebody behind you in a sneaky fashion. Klumpke's palsy is when there's damage to the lower trunk, so C8, T1. In that, we're going to see something called Horner syndrome, and we'll take a look at that, what that means. And that usually just mainly affects the hand more so as opposed to Erb's palsy, which is scapula down to fingertips. You could also have a total palsy, which is damage to all trunks. So in that case, you're going to have really a flaccid arm and no sensation. So the damage associated with the brachial plexus injury can be categorized into three types. The most mild type being a neuropraxia, where this is just a stretching of the nerves. So the neuron and the sheath are intact but compressed from the stretching. And you usually have a complete recovery with this type of injury. Now, the axonotmesis is a more moderate type of injury. So that's when the axon is damaged, but the neural sheath that protects the axon is intact. So the neurons can grow back because it's protected, and recovery varies, but there's usually some functional limitations left over. It's never usually a total full recovery. And then you have neuromesis, which is the most severe, and that's where you have a rupture or complete avulsion of the nerve, and that is associated with a poor recovery. This picture shows those three types of injuries. So you can see the neuropraxia, where there's a stretching of the axons. So you can kind of see how if you were to kind of pull it like a piece of wet spaghetti, you're pulling it, but then the actual spaghetti is compressed from top to bottom there. And in the axonic mesis, you can see where there now is breakage in the axon, but the overlying sheath is intact. And in the neuromesis, you can see there's just a complete breakage in both the sheath and the neuron. What risk factors go into developing an Erb's palsy? So a big baby, 9+ pounds means difficult delivery. Also means you have a large baby in a small little apartment, so not a lot of room to move around. Things can get stuck. You can be stuck in a position where your head is bent to the side and your shoulders depressed, and you're putting some traction for a long time on that plexus. If you hear a parent saying that the baby's shoulder got stuck, that shoulder dystocia, that is a big risk factor for Erb's palsy. Because once that shoulder gets stuck, you have something that you're bracing the shoulder against while the head's moving and sometimes being rotated and pulled, and that can lead to an injury to the brachial plexus. Any type of difficult or assisted labor and delivery, you got a lot more pulling and turning, and doctors are doing whatever they can to get the baby out, because the life of the baby is most important, but that can lead to that traction injury, which also can be associated with what? Torticollis. So sometimes you see those go hand in hand. Now, the typical presentation for Erb's palsy, like we said, is the waiter's tip position. So the shoulder is going to be positioned in extension, internal rotation, and adduction, so right against the body. The elbow is extended. The forearm is pronated so that the fingers are facing backwards. The wrist and the fingers are flexed, which then leads to that waiter tips type position. Here's an example of a baby with a left Erb's palsy. So you can really see that traditional waiter's tip position where the left arm is positioned in shoulder internal rotation, adduction, elbow extension, wrist and finger flexion, which really makes it hard to bring hands to midline, to grasp the fingers together, to get that sensory input into the hands, bring the hand to mouth, explore toys, grab onto toys with both hands. It really impacts everything from the get-go. Knowing that traditional waiter's tip position, you can then gather which muscles are going to be affected. So I'm not going to go down the entire list, but if you're in internal rotation, well, the external rotators are going to be weak. So you might have paralysis of any number of those. Same thing with, your second elbow extension. So, biceps brachii and brachialis and brachioradialis are all affected. So just by knowing the positioning, you can pretty much gather which muscles are going to be have some sort of weakness. Let's talk about the consequences to muscle paralysis in these kids with Erb's palsy. So when you don't have a muscle or a muscle group available to you and you still want to move, you're going to find a way to do it. And that usually occurs through muscle substitution. And when that happens, that's when you'll see those atypical movement patterns. So the child's able to do what they, want, but it just doesn't kind of look quite right. You will see soft tissue contractures. So that waiter's tip position, you prolonging the time that you're in that position causes those muscles that are working well to adaptively shorten because they're resting in that shortened position. And there's not a lot of opposing muscle pull because those opposing muscles are weak. So you see soft tissue contracture. That's really one of the goals too of preventing that from the get-go. Abnormal bone growth occurs from the uneven pull on the muscle, on the bone itself. So when you don't have, like I said, that opposing muscle pull, and there's only one direction being pulled on the bone, you can change the shape or the direction of the bone. And sensory loss is usually present in these kids, but the degree of sensory loss doesn't always align with the degree of muscle involvement. So you can't assume that a child who is mildly involved has mild sensory loss. And luckily for these kids, their grasp is relatively intact, although you will see some altered grasp patterns, but they are, able to grasp onto things. It just might not be in, the quote unquote typical grasp patterns that we see. What does this mean functionally for the child with Erb's palsy? Well, bilateral manual skills may be difficult if you think of your ADLs, activities from tying shoelaces to cutting food to dressing and undressing. Those all, are made much more difficult when you only have one available arm to use. Reach and grasp is going to be difficult. So being able to reach out in a functional way is affected. Your gross motor activities. So think about the baby, just even creeping, pulling to stand, catching a ball, even just playing with a toy in midline, how all those things are affected. Because of the sensory loss, you can have a neglect of the arm, self-abuse when things kind of are numb, or you just don't have sensation. It can be subject to injury. You might not feel that water is too hot, or you don't feel that you just got cut. You can have issues like that as well. And later on in adulthood, because of the poor movement patterns and the poor positioning of the joint, in adulthood you could have shoulder pain. What things do we want to test for in our examination? So obviously active and passive range of motion going through the whole upper extremity, but even into neck, trunk range of motion. A developmental screening is important to see how the arm is affecting the child's attainment of age-appropriate gross motor skills. And then we want to look at the motor function specifically of the arm. And we have some that are, specific to brachial plexus injury. The active movement scale is a way, you'll see that in a second, but it's a way to grade muscle strength or muscle function that's not using a manual muscle test. For older kids, you can use a manual muscle test if they're able to follow those directions appropriately. And we're going to look for typical patterns of movement. So for sensation, we want to check sensation and just to understand that it doesn't always correlate to the degree of motor impairment. You could have a really impaired arm strength-wise and the sensation is not nearly as affected or vice versa. If you want to be that super mean PT, you can do the pinprick. I guarantee you will not make friends with the child. There's also something called the water test. So if you leave the arm or the hand in 104-degree water for 30 minutes, you want to look for wrinkling in the skin, like how your fingers become raisiny. If there's no wrinkling, that gives you an idea that sensation is decreased. We also have something specific to brachial plexus injury to look for functional status of the arm, and that's the mallet classification, which we'll look at in a second. And that is good for kids over the age of 3. This is the active movement scale. So it is based on observation. So you can watch a child go through their normal play and see in a gravity eliminated position or against gravity what they're able to do. And it's graded on 0 to 7, with no contraction being 0 and full motion being 4 with gravity eliminated. And then against gravity, if you can do half of the range against gravity, you get a 5. A little more than half, but not quite full, is 6, and full motion would be a 7. Here is the mallet classification. So it is graded on grades 1, which is no function at all, to grade 5, which is normal range of motion. And it goes through a bunch of different movements. So the first being global abduction. So just abduction in the frontal plane. How high are they able to actively lift that affected arm? Then we have external rotation from a bird's eye view. Hand to neck. So bringing your hands to the back of your neck. Then we have hands to spine. Go see how far up the spine you can go. Can you go all the way up to T12 or higher? The hand to mouth, which is that trumpet sign. So are they able to bring their hand to the mouth, but they have to bring their arms up in abduction to do so? And how much internal rotation, again, from a bird's eye view. So outcomes and goals. What's the ideal outcome? Well, ideally, we'd like a complete return of sensation and motor control. A good prognosis is if we have anti-gravity bicep activation by 3 months post-injury. Now, we all love an ideal outcome, which is a complete return of sensation and motor control. And a lot of these kids will say have an ideal outcome, but the vast majority will have some sort of limitation, and it might not be visible to the average eye, but you as a therapist would be able to pick that out. So the arm will never look quote unquote normal like the other one. There will be some sort of movement limitation. Now, if biceps returns by 6 months, they will have definitely some quality of movement or movement compensations. Surgical intervention, there are some options like neurosurgery, muscle transfers, osteotomies, tenotomies, and even Botox. And those are really saved for the more severe cases. What are the goals in regards to physical therapy? Well, ideally, we want to prevent a lot of these issues. So, the baby's born, their arm is in that position, but they don't have soft tissue restriction yet. They don't have bony changes yet. So, whatever we can do, educating the parents to maintain the range of motion that they have, passively and actively, maintain that joint integrity, and to really work towards attaining normal strength and developmental milestones, all of that will serve to prevent all the other complications that go along with this injury. Later on, as kids get larger bodies, bigger, we really need to work on maintaining that range of motion and strength. It's the real, use it or lose it philosophy. As they get older and, maybe they're not playing as much and they're not active as much, they might not be using that arm as much, especially if it's their non-dominant hand. That might lead to now some range of motion strength limitations. We always want to encourage the use of functional bilateral activities as much as you can. You don't want them really compensating with trying to figure out how to do all these things with one hand. We really want to encourage them using both hands. And we want to be cognizant of pain. What is our intervention going to be as physical therapists? Well, in the first 7 to 10 days after injury, whether it's birth or trauma, we really need to rest and immobilize that arm. So we want to make sure we're giving time for that nerve to kind of calm down. And with babies, you want to either use like a pin or an ace wrap. You kind of put their hand on their chest. So it keeps their wrist in neutral. It bends their elbow. It takes the arm out of that extreme internal rotation. And if they rest like that, that's a good position for the first, week to 10 days. But in that time, you're going to take some baseline measurements. You want to know the active, passive range of motion. What do they have available to them? And you're going to give a home program of range of motion. The beginning is, after this time of immobilization, you're going to start to educate the parents on how to do, passive range of motion with really nice alignment and staying kind of within their available range initially. And then we can work towards pushing into a new range. But initially, we're going to just kind of maintain that available range of motion. We want to educate the parent on sensation. So if this child's lacking sensation, they might not feel it when their arm is pinned underneath them or if they get squished in something. So you have to be cognizant that, they have to be protective of that hand because it might not sense pain or temperature. Positioning, like we said, we want to avoid, prolonged positioning with the elbow extended in that waiter tip position. And then just ways functionally to get therapy out of play. Different little tricks and techniques they can use to get some active, supination in the arm or wrist extension or shoulder abduction. In PT, we're really focusing on active mobility. We don't want to spend too much time doing passive techniques. We really want that arm active. We work on strengthening of not only the arm, but the trunk and really giving a big focus on that bicep, right? Because we really want that bicep by, 3 months, at least 6 months, but really trying to get it by 3 months. A deltoid, especially, and those scapular stabilizers. But again, knowing all the muscles that are weak, we need to address all of those muscles that are affected with the brachial plexus injury. Kinesiotaping or different taping techniques I've used to help with the scapular instability, to encourage some active external rotation, to encourage some active supination. There's a myriad of taping techniques for that. We also have splints that can be used, whether it's a resting splint or a dynamic splint, to help keep the elbow in flexion, to help promote supination and keeping the wrist in neutral. Constraint-induced movement therapy, you have that available to you too. So by constraining the unaffected arm, you can really force the child to manipulate toys, reach, grasp, play for things with the affected arm. And we always want to monitor for scoliosis. So you know how, when you have those um, muscle imbalance in the arm and the scapular stabilizers, how a scoliosis can develop as a result. And we also have NMES. It's been shown to affect active range of motion better, but that is something that is available and has some evidence for. It's important to know when to refer out. So if the baby has any signs of a nerve root avulsion, you might see something like Horner syndrome. So that you really have to take a look at the eyes. If you see like meiosis, ptosis, a lack of sweating, if the eyes look recessed, if there's abnormal pupillary contractions or different color irises in the eyes, those are all signs of Horner syndrome, and that needs to go to neurosurgery. We know that surgery is most effective within 3 to 6 months post-injury. So you really want to closely monitor progress. And this is not one of those things that you want to say, all right, let's give it another week, let's give it another week, let's give it another week. If you're not making progress, that by that 6-month mark, you need to refer out because the surgery really later on is not going to be as effective. What is the prognosis for these kiddos? Well, 90% will have a complete recovery. But when we say complete recovery, that doesn't mean perfect recovery. It means the brachial plexus has recovered, but these 90% will be grouped according to their residual limitations. So the vast majority, 70% of this 90%, will have mild residual limitations. So some scapular winging, shoulder abduction, maybe 90 degrees, maybe a little bit higher, but they'll have, good hand function, normal sweat response, good sensation. Their arm, like I said, might not totally look the same as the other arm in the terms of quality of movement, but to the untrained eye, it would look pretty darn good. The next group, the moderate group, makes up about 22% of these 90%. And with these guys, you have a little bit more moderate scapular winging. Abduction might be limited to less than 90 degrees. You might have an elbow flexion contracture. Supination might be very difficult. So finger extensors may remain pretty weak, and you might have some loss of sweat and sensation. And only about 8% have a severe, uh, severe limitation with their recovery. So with these guys, they might have poor or no hand function, severe loss of sweat and sensation, and the whole upper extremity may become atrophic. We are in the home stretch. This is the last one. Now we're talking about clubfoot, which I really hate that name. I just think it's just such a terrible, terrible name. But you'll also see it in the literature as congenital talipes equinovarus, or CTEV, which I like much better. What's the epidemiology for CTEV? Well, it occurs in about 1 in every 1,000 live births, with a slightly higher incidence occurring in males over females. And about 50% of the time, both lower extremities are affected. There's been some recent research to suggest that a genetic mutation may be causing the CTEV in some cases, but we know, as the other issues that we talked about today, that uterine constriction can cause malpositioning in utero and affect the development of the fetus. So that's why it's so important, if you have a baby that's presenting with CTEV, that you screen for hip dysplasia and the brachial plexus injury and torticollis, because those are all associated with uterine constriction. There can be some non-idiopathic causes such as arthrogryposis, foot dorsiflexion muscle paralysis, musculoskeletal anomalies, polymalformative syndrome, amniotic band syndrome, which can also cause limb amputations, myelomeningocele, which is spina bifida, which you'll learn about later. But that's another reason why to do a thorough exam to see if there's other signs of spina bifida, and Charcot-Marie tooth disease. A good way to remember all the different changes in the foot is to remember the abbreviation CAVE, CAVE. So there's a cavus foot, so that medial arch is increased. You'll see adduction of the forefoot, varus of the hindfoot, and equinus of the ankle. Now, don't get confused why two of the bullets are blue and two are yellow. They're not grouped together by color. It's just the PowerPoint slide does not like me, and I can't figure out how to get them all the same color. So they all go together, cave. What's the pathophysiology in CTEV? So the joints themselves are malformed, and this includes the ankle joint, the subtalar joint, calcaneocuboid joint, and the talonavicular joint. I apologize for my barking dog, but I've repeated this like 16 times and she won't stop barking, so we're just going to try to power through. Besides malformed joints, we're looking at contracted muscles, including the Achilles, the tib posterior, the flexor digitorum longus, the flexor hallucis longus, flexor digitorum brevis, and the abductor hallucis. The ligaments also are contracted and also thickened. And there's a whole host of them. I'm not going to read all those out. You can read them on your own. But just to give you an idea that it's not just tightness in the muscles that's causing the foot to be in this position. The Demeglio scale is used to classify severity of deformity. So you give it a score between 0 and 20, and that is based on measuring the degree of equinus and varus and derotation of the calcaneus. If you can see, that little picture shows you the different things that go into it. And depending on how much motion is available, they're given certain points for it. Now, you can get other points for having creases or cavus foot or poor muscle contraction. So the higher the score, the worse off the case of CTEV. And scores of less than 13 or equal to 13, generally by 2 years of age, these have been treated non-surgically. So we have some non-operative treatment options and some operative treatment options, and sometimes they're both used in conjunction with each other. It's not a single route that's taken. The Ponseti method is the most common conservative treatment approach. It's old. It's been going on since the 1940s. And what it implies is that you do some gentle manipulation of the foot and the ankle, followed by a series of long leg casts that usually are done weekly, and it gradually corrects the foot position. If it started young, it can be corrected in 6 to 8 weeks since the younger foot is much more flexible. Look at this tiny little baby foot. When I was an outpatient treating adults, I used to cringe if I had to touch somebody's foot because, let's face it, adult feet are gross. But oh my gosh, there's just something about little baby feet that are so cute. So anyway, this is what the Ponseti method is. What it does is the first cast, they work on the forefoot correction first, so reducing that adduction. So it's really trying to align the forefoot with the hindfoot. And towards the end, as they start working on the equinus part, sometimes they need to do an Achilles tenotomy before the last cast. And then that last cast will stay on for 3 weeks to really set the foot. There is a relapse rate of about 30% with the Ponseti method. This has been associated with poor brace compliance. And a study by Gelfer et al. Has found that if the child has poor everter muscle activation, then this also is associated with a higher rate of relapse. Now, to prevent relapse, the children are put in an Iowa brace after the serial casting is completed. And this brace holds them in forefoot neutral in an externally rotated leg position with their ankle in a little bit of dorsiflexion. And there's a dial on the bottom that can control it. You can use it, unilaterally or bilaterally. And the brace is worn full time for 2 to 3 months after the casting is completed. And then for the next 3 to 4 years, yes, I said years, the brace is worn during sleeping at night and during nap time. So you can kind of see how brace compliance may be kind of difficult as the child gets older and difficult for the family to keep up for that amount of time. This picture is just showing you the progression with the serial casting. So you can see in the first couple weeks that they're just kind of adjusting that forefoot position, and the equinus doesn't really move much. And then after that second, third, really the fourth week, and definitely by 5 and 6, you see how the foot starts coming up into a more neutral position. Just another picture of a baby being casted, just to give you an appreciation of the size of the child. You can see in comparison the size of the hands that are on their legs, a little itty bitty thing. You see that almost that forefoot is almost corrected with that. They probably have another one to go. Here you can see the before and after, which I think gives you a nice appreciation for, how great of an outcome you can get with just a few weeks of serial casting, especially, seeing how, the feet were positioned before and knowing how there are changes to the joint structure, and yet you're still able to get a nice result. Since the Ponseti method, there's been another method to treat CTEV called the French Functional Physical Therapy method, and this started in the 70s, which is very similar, but it's more of a combination of splinting, PT, and then as needed, some minimally invasive surgical procedures. So what happens is the child needs daily manipulation of the joints. So a PT will every day do some joint manipulation, stretching, and strengthening of the affected muscles. And then they follow that by immobilization of the foot using taping. So it's not as restrictive as the serial casting, it's more taping, but it has to be done, every day. This method does have a similar success rate and relapse rate as the Ponseti method does. It does take a little bit longer for full correction. So we're looking at 5 months instead of, 6 to 8 weeks for the young kids with the Ponseti. And it does take a lot of parent training, and the parent really has to be invested because they need to continue with all the things that they've been taught until the child is walking independently. Uh, they use a below knee aquaplast splint until 2 to 3 years of age as needed for positioning. Uh, with kids who have chosen the French functional physical therapy route, there tends to be more need for surgical intervention if they haven't gotten a full correction with the French functional physical therapy method as opposed to the Ponseti. One of the more common surgical treatments you'll see is an anterior tibialis tendon transfer. And this, they wait until after the child's 2. And the reason for that is because they need to wait until the cuneiform totally ossifies because they're moving the tendon to the 3rd cuneiform. Afterwards, the child will be in a short leg cast with the foot in neutral for 6 weeks. They are allowed to weight bear as tolerated and will go to PT for gait training and range of motion. Another common surgical procedure you'll see is the posteromedial release. And this mimics the Ponseti, but instead of using mobilization and stretching over time, it goes in there and cuts what it needs to surgically. So first they release the anteromedial structures to correct the forefoot. Then they'll do a posterolateral release to correct the equinus. They'll use pins to hold the foot in the alignment that they want it in. So after those structures are released, now it's held in the optimal alignment, and then the children are mobilized for 6 weeks in a long leg cast, being non-weight bearing. After the 6 weeks, the pin is then removed. So what's the prognosis for these kiddos? So you probably guessed it, early treatment is key. So a study by Garcia et al. Found that babies with severe CTEV, so that Demeglio score of greater or equal to 11, they use the AIMS to assess their gross motor skills because, it's a concern of parents, especially if they're braced in that Iowa brace, and that really impacts their ability to independently be mobile and gain motor skills. Parents want to know, is my child going to be delayed because of this? Well, Garcia et al. Found that at the 3 to 6 month range, there really was no difference in gross motor development. By 9 to 12 months, they did find a gross motor delay in the kids who had CTEV, and this was regardless of severity level, whether it was unilateral, bilateral, it didn't really affect the outcome. However, when they followed up at 15 to 18 months, the amount of delay was no longer significant. That could be because the AIMS, you're kind of hitting the ceiling at that point, or it could be that then at that point, kids are only wearing the brace at night and they're starting to be a little bit more mobile. Now, Zapata et al. Found that treated clubfoot had no impact on gross motor skills at 5 years old, regardless of initial severity, again, if it was unilateral or bilateral, or if it was treated conservatively or surgically. So we're looking at maybe a delay at around the age of onset of pulling to stand and starting to walk, but later on, these kids are in the quote unquote typical range on their Peabody scores. And if you look at the bottom, Mia Hamm and Troy Aikman and Christy Yamaguchi all performed, a high level in their sport, and all three of them were born with clubfoot. So when treatment isn't initiated early on in life, it almost always requires some sort of surgical treatment or correction. Khan et al. Looked at kids over the age of 7. I believe the mean was about 8.9. Um, and they used the Ponseti, but first they all had an Achilles tenotomy. So they had the tenotomy, and then they used the Ponseti after, and they found they were able to fully correct the feet at a rate of 86%. Now, there is some more research that advocates for going right to the Ponseti as the first method of treatment, even in late treatment. But usually, the later the later on, the later things go, the more surgery is required to correct the foot position. Now, what happens if they are not treated at all? Well, unfortunately, this happens more so in developing nations where there may not be access to care or funding for care. And, these people who have clubfoot, they're ambulatory. And you could take a look at the video to see. But you can tell with all the biomechanical forces going on in their foot, ankle, and leg. You just imagine all the long-term sequelae that are going to be going on. Okay, that's it. Hopefully I kept your attention. You got through everything. Like I said, don't wait with your questions. I have my email down there again, so jot it down real quick and let me know if you have any questions. And that's it. So thank you guys very much, and we'll see you back in class soon.